who is recording now?
Me. That is me.
On your computer, right?
Yes, on my computer.
Good. And Rafael will do the same. Okay, and I will stream. I won't save on my computer. So how should I call you? Dr. Devgan?
Uday? Call me Uday. I'm very informal.
Me too. It is really a pleasure having you here. I'm sure I will learn a lot.
That's why I'm here to learn.
Can I say hi to Dr. Devgan? Hi from Bulgaria. And
good morning. Of course.
I'm really happy to be with you in this presentation. So I'm looking for an exciting meeting now.
I'm looking to learn from you, Lukan. I love your videos.
I love your channel and the huge editing power that you have, you yourself or the team behind you, because the editing and the video quality constantly evolves.
Yeah, I'm learning.
We all learn, but this is a tremendous amount of work to produce at least 2 to 3 videos a week, and
yeah,
it's either you don't sleep at all or you have a good team.
No, we're making. I post a new video every day.
This is awesome. Yeah.
Hello, Uday. It's a pleasure to have you here. And yes, we all get very amazed at how productive you are and with such good content on your channel.
You say productive. My wife says I'm crazy.
You can be both.
Okay.
So we are only waiting for Dr. Megur. Do you have news from him, Felipe?
Yeah. Hello, everybody. This is Dr. Deepak here.
Oh, how are you doing?
Hello, Dr. Deepak.
Hi. Hi. Hello, Dr. Mishev, Dr. Veles, and Dr. Uday. Nice to see you.
First, I will say in the name of our university, University of São Paulo, and the Escola Paulista de Medicina, or Paulista School of Medicine. It's a pleasure having you here. This all came with an idea from Felipe Taguchi, who is our former fellow. So he put a lot of effort in having 4 of you here with us. And the idea is to informally discuss surgeries. So each one of you will present 2 cases, and each one of you will have half an hour for those 2 cases. The idea is that yourselves stop and ask questions to the other ones, and they can also interrupt you and ask for some more information. So the discussion will be focused mainly on the 4 of you only. There will be very skilled and experienced surgeons on our audience. So in some occasions, one of us co-hosts will be able to ask for one specific information or input from someone from the audience. But mainly, you should discuss the 4 of you. I mean, if you have any other idea on how to proceed, I'm completely open to that.
So we'll show the video from our desktop. Is that how you want to do this?
I think that's the idea to begin with. If we have problem with that, then we have your videos. Rafael has your videos, and he would try to stream it from here. But it shouldn't matter.
Okay.
Because for Zoom, it doesn't matter where it's coming from. Only if your connection is not that good, maybe Rafael would be better, but it shouldn't matter. But let's try. We are all learning from it, right? Okay, and we are streaming now. Okay. Rafael, you should you should click play on your keynote, so everything around disappears. Let me give you the link. I'm sending the link to Bidudo now. I'll send you. Let me see here. So for the co-hosts, I'm sending you the link through the WhatsApp, because you can't copy and paste here. And if you could, Felipe, send the same link to our presenters, I would appreciate it. Okay. You should keep muting people. Huh?
So, Neto, what do you think about starting with your videos when we?
Okay, that's all right. Felipe.
I just wanted to keep Dr. Lukan and Dr. Deepak in sequence because they're challenging videos. I think will complement each other. So, the rest of the order is, I think it's.
That's all right. That's all right.
Felipe, I can be number 2.
Okay, sure. Then perfect.
So, should I start streaming my video?
Just wait minutes.
2 more minutes.
Okay.
I'm looking forward to your video, Dr. Rosatelli. Neto, I love the way you operate.
Oh, thank you.
I wish I could operate like you.
Oh, I'm sure you do, and thank you for the kind words, Uday. And my videos, one will be one technique that I often use in my routine surgeries, and the other one is just to raise some controversy or to raise some discussion. And that's the point. I think it's an issue that a subject that is very important in these days with premium IOLs being used. And I think you see, I didn't want to disclose what I would be presenting before, but I just uploaded the videos in my channel. So if the streaming is unstable, maybe people can follow on the YouTube. But I hope it generates a good discussion, and I'm sure it will.
Okay, so you're right on time. First of all, I would like to thank the presenters for accepting this invite. It's an honor to have all you here from different parts of the world. My name is Felipe Taguchi. We are here from the Federal University of São Paulo. This is a weekly meeting of our surgical optics sector. As we are here, I'd like to thank as well Dr. Chanon and Dr. Obdulio, Rafael Kobayashi, and Rafael Arantes for helping with this coordination and organizing this meeting. So, This meeting, in this meeting, we have 4 expert surgeons that we will present 2 cases each, and one is a routine case, so we can see how the Phaco is performed around the world. And feel free, anyone who wishes to ask questions or comments, please. We are all here to learn. And the second one is a challenging case. I think everyone has different ways of approaching it. It will be interesting to see how each one does it in different situations. So, I'd like to invite Dr. Neto Rosatelli so he can start his video's presentation. Firstly, I think we'll try to share the screen, okay, Dr. Neto? Yeah. And if there is any issue with the videos, we can link their corresponding uploads on YouTube or try to reproduce it from host, okay?
Okay. Thank you, Felipe.
I thank you very much.
Hello, everybody. I would like to say that it's an honor to be here in such a useful company. And I take the opportunity to greet our international guests, Dr. Uday Devgan, Dr. Lukan Mishev, and Dr. Deepak Megur. And it's a pleasure to be here, and I hope it will be a very productive meeting. Okay, is it on screen, Felipe? So, I'll first show one of my routine techniques I employ. It's not the one I employ the most, but it's a technique that I find very good for soft to medium hardness nucleus. And it's a very satisfying technique to use. And to complement this technique, this Phaco technique, before I do the Phaco, it's important to release the nucleus and the epinucleus completely, so the nucleus will rotate and the technique will work. It's not every time that we are able to achieve let's say, a very beautiful rotation and emulsification of the nucleus, as you will see in this one. But even when the rotation of the nucleus fails, it works very well, and it's a very, let's say, a very little invasive or less invasive techniques. So there is almost no movement of the phaco tip, and things happen only by the fluidics of the intraocular flow when we are emulsifying. And it's very important to achieve a very good hydrodissection, and I also employ a hydrodelineation technique here, so that the nucleus and cortex are released from the capsular bag. And you will see, as many people follow me on the channel, that I have a technique that I developed and you're seeing now, which I call the spin. It's spinning the nucleus many times in each direction, so to not only achieve nucleus release, but also if possible, all cortex be released from the capsular bag. So that cortical aspiration is greatly facilitated, or even it is not even necessary, because all cortex is released. So I'm beginning the technique, which is a carousel. It's a very known technique. It's not very easy to be proficient in that. It requires a little training, But when it goes well, it's a very fast, and as I said, there is very little movement of the phaco tip inside. And only the epinucleus is remaining now, and aspiration is very easy because the previous maneuvers, not only the hydrodissection and hydrodelineation, we used it from the capsular bag, but also the nucleus spin. Another technique I like to do is to hydro-implant the IOL. And the reason for that is that by avoiding use of OVD in that step, there is very little OVD remaining after the IOL implantation. And so it not only speeds up the surgery, but also avoids IOP spikes afterwards. And it's a very easy technique to use, it's very useful, especially with hydrophilic IOLs, with injector type, with plunger type injections, when you just press like a syringe. And in screw type injectors, it's not possible to use this technique easily. But I think it's a very easy and safe technique, even for beginner surgeons. And that's the technique of IOL implantation I employ most of the time. So now the rest of the surgery is just sealing up the incisions. And I really would like to know the participants' view on these techniques. The technique I use most for nucleus management is a mechanical fracturing technique, but I wanted to show this other one, which is not very employed by many surgeons, and I like very much. So I would like to see the participants' opinion on that.
Beautiful surgery, Neto.
Thank you, Uday.
So yeah, I like very much how you carousel the nucleus, but as you said, there's a lot of subtlety. It's not as easy as it looks. The phaco probe has to be on its side, and you really have to get the correct angle to get the nucleus to spin.
Yes, that's the most challenging part, is to present the phaco opening, the tips opening, in a, let's say, in a square aspect to the rotation, or so that to achieve nucleus rotation. If you step too much on the pedal or too little, it doesn't work. But with some practice, you get the feeling, and when the nucleus is rotating, you just keep pressing at the right amount, and things go by itself. What happens most often is that the nucleus, as it gets smaller, it gets out of the bag. But it's no problem. You still can emulsify it at the capsular, at the safe zone plane, and it's very safe. It's a very safe technique. This one went beautifully, so I decided to show that, so that it's easy to appreciate how the movement goes and so some of the mechanics of the technique. It's very important to be successful, to achieve complete rotation of the nucleus. And many people ask me if the spin is not aggressive to the zonules. And as the forces are applied tangentially, it is distributed to all of the zonules. And if you can make the proper path completely circular, it's really, there is really not much power, not much force applied to the zonules. It's very zonular friendly.
Let me make a comment. Some people in the chat are asking if beginners can do it, but I'd like to listen to the opinion of Dr. Mishev or Lukan, as well as Dr. Megur, Deepak Megur. Can you Can you explain if it can be done by beginners or not?
Hi, Dr. Neto, that was wonderful. I think you looks like magic in your hands, but I'm not sure whether it is reproducible by a beginner's version. I think you need to understand the fluidics a little bit better. What flow rate do you use, Dr. Neto, for your surgery in your scapulocarosolic lens? What is the flow rate you use?
And I'm using the Constellation machine.
Okay.
And yes, and flow rate is 15 to 40 millimeters per minute and cc per minute. And the vacuum is the machine is operating on Venturi settings. So, and the aspiration, the flow rate is, yes, just as I said, that's 15 to 40, and vacuum is about 5 to 600 millimeters of mercury.
Again, I think a beginner surgeon, I think he needs a little bit of understanding of fluidics, and once you get the hang of it, probably it will be safe enough. But in the initial part of the learning curve, I think you just need to understand the basics first, and then probably. But Dr. Neto, he just does it wonderfully well. And you know, there is no epinucleus left. Everything comes out in a different. Most often, they're not even cortex comes off in his hands. So wonderful, Dr. Neto.
Thank you.
If I can comment, I think that the technique is wonderful and is applicable to every surgeon as long as the hydrodissection is sufficient and well done. Another thing to note is the hydroimplantation of the lens. I also use that technique, and I completely agree that on the next day you don't have refractive surprises or less of them. You don't have IOP and the cornea is clear. You actually turn around less fluid in the eye because you skip the step with evacuation of the visco. So beautiful surgery. Thank you, Dr. Neto.
Thank you. Yes,
I'm sorry, but there is one more question, and this is my job here. How many times you go clockwise and anti-clockwise?
10 times. I try to go 10 times. It took me almost 1 year to get the number. And I methodically, let's say, tried or experimented how many times should I turn. And 10 times, after 10 times, there is no difference. But one can feel when everything is, the nucleus and the epinucleus is completely released. The friction you feel changes, and you can say, no, that's enough. But it takes a long time to do. It's not important the speed. The speed of the spin is not important at all, but the number of times you turn in each, and it's very important to turn both clockwise and anti-clockwise in both directions.
I have another question here from the audience. They are asking if I can use this technique with a straight tip.
And I think it may be more difficult, but I think yes, you can get the right angle.
Can I have one more question here?
Oh, yeah, sure.
Have you studied any PCO rate, the posterior pacification with this technique? Because the rotation, forceful rotation, I think it really takes care of the equatorial epithelial cells. You know, you do it 10 times clockwise and anti-clockwise. Have you found the incidence of PCO slightly lesser compared to maybe your previous technique or something? Do you have any study or anything about this? Because this is the nucleus rotation itself will take care of the equatorial epithelial cells. It's like polishing the equatorial epithelial cells. You don't have access to any instrument which can reach the equator. So it's just an observation that have you done any study in the past?
And let's say not a formal study, but from, let's say, personal observations, and that's a lot. I do many surgeons per year. It's very noticeable that the posterior capsule opacification is much less than, let's say, with the previous way that I did surgery, which was not with this technique of the spin. I do the spin in virtually all my surgeries, and when I started doing it, the initial intent was really to just release the cortex, but what you just said is very important. I really believe, but I have no way to assess that the epithelial cells are very, the removal rate of the epithelial cells is very high. After the maneuver, I can observe the capsule, at least in the area that I can see, and the capsule.
Using that technique.
Well, Philip, as I understood, it was asked if inadvertently I aspirate the nucleus, if there would be any problem. Is that?
Yes.
Yes. No, not at all. Of course, when you have the epinucleus cushion behind the nucleus, it's easier and safer to manage the nucleus, but it doesn't. It's not very. It seldom happens that I accidentally aspirate a good portion of the epinucleus in this technique. The nucleus is already very movable, let's say that, and it's not, well, I can't remember if this already has happened to me, but even if it would happen, it sometimes happens when I make the spin, move a great amount of cortex and a nucleus comes out. In fact, this makes it easier because then you have more space in the bag when you do the nucleus cracking and to work with the nucleus. Maybe in harder nuclei, that would be a problem, but in harder nuclei, usually I don't do the spin very much. It's not that necessary because there is much less cortex and etc. So it shouldn't be an issue.
Okay. Can we go to the next video, Dr. Neto, please?
Okay.
As some have already told here on Zoom and personally, the video gets a little bit choppy sometimes.
Okay.
So I'll be sharing the YouTube links on the chat. Zoom doesn't allow to copy the link, but you can look for Dr. Neto Rosatelli's channel. It's the 2 latest videos on his channel, okay?
okay? Is it there, Felipe?
Yes.
Yes.
So, this next video, I will, most of the surgery will be fast forwarded because that's not the whole point of showing it, but I included the whole surgery so that people can see, well, how it was done. But the main purpose of this is to raise a discussion about the, well, if implanting a single piece IOL in the sulcus, if that's okay or not. That's my intention here. So this is a very dense nucleus, and at the end of the nucleus emulsification, I notice that there is a radial tear in the anterior capsule that extends to the posterior capsule periphery.
Neto, do you want to stop the video, and do you want your poll to be launched? Not yet.
No, I think after it, I think afterwards, Wallace. So, I should say now, Father, forgive me, I have sinned. And yeah, and here goes the IOL. And we'll discuss I think it would be a very good discussion of the issues here. And it's a subject that I think it needs to be more evaluated. And I really should say that's not what I advocate, but I sometimes do that. And I know from personal communications that a lot of surgeons do that, but many people don't tell. And I would like to see how the audience manages these cases when there is no alternative IOL present at the operating room. So we end up with a forehead to single piece hydrophilic IOL in the sulcus. Philippe, I will just change to a keynote screen.
Okay.
Okay.
I would also ask if you could, I don't know if you're going to say it in your presentation, but if you could show us the exact moment and freeze the frame where you noticed there was a tear.
Yeah, I noticed just at the end of the epinucleus aspiration, and I couldn't see, even reviewing the video afterwards, when the exact moment it happened. You want?
May I launch the poll?
Yes, surely, Wallace.
Neto, which IOL were you using in this case?
You're asking me? Yeah.
Which one?
I'd like to see the poll first.
Okay.
So as not to influence anything.
I'm waiting a little bit, so we have 160, but everybody's voting.
Okay.
And before it ends, I would like to know what do you think it will come?
Yeah.
For you and for our other presenters. How many would implant and how many wouldn't?
I would.
And what do you think will be the answer of the audience?
Well, I'm seeing here, and I'm surprised. I thought there would be much less people saying it would implant the single piece acrylic IOL in the sulcus, because it's not a good thing. I don't think it's okay. And most of the Yeah.
And let's wait. We're gonna share the results, but there's people still voting. I think I can share because I think they stopped voting and it takes too long. So I'm gonna share the results and then you can discuss.
Okay.
Can I comment on that?
Sure.
Let's first say that the surgery was really good. The only thing that I note, and Dr. Neto also acknowledged it, that he went out from the AC without putting viscoelastic to protect the posterior capsule rupture from enlarging. But in terms of implanting the single piece IOL, and especially this one, this lens is perfect for this situation. Why? Because you have 4 independent haptics, and I have done that numerous times. Diagonal optic capture. You can tuck 2 of the haptics behind the anterior rhexis and 2 of the haptics in front of the anterior rhexis, and you achieve stable optic capture with this lens. In fact, I have done this with plate haptic like Oculentis Comfort, and I cut the haptic in order to create 4 independent haptics in order to make diagonal optic capture. So this is a maneuver that can save a lot if you have intact anterior rhexis, as in this case.
Well, that's a very interesting technique you just described, Dr. Lukan. And I really don't think that two haptics, single piece IOLs with 2 haptics are stable in the sulcus. And even this one, as the overall diameter is really not enough or sufficient to reach the sulcus. This IOL in case has 11 millimeter overall diameter. An IOL to reach the sulcus needs at least 13, ideally 14 millimeters in diameter. And one of the reasons I wanted to raise this question is just to call attention to a problem that we are increasingly having with premium IOLs. And we really don't have an ideal or premium optic IOL, be it multifocal or toric, especially for sulcus implantation. And as we increasingly use more and more these IOLs, I think we're, if something untoward happens in the surgery, we're in the opening. We don't have any alternative. If it's the first eye of the patient, you can opt to a 3-piece foldable IOL, which is undoubtedly the best option when you have to do a sulcus implantation. But if it, for example, it's the second eye where the other eye has a multifocal IOL or even a toric correcting a significant amount of astigmatism. On the second eye, we will have not this possibility because premium IOLs are not ideal to be placed in the sulcus.
If it's a toric patient, I think one of the things that I end up doing in these cases is if I put a sulcus lens in, I'll increase the IOL power sufficiently. So that let's say the patient has 2 diopters of corneal astigmatism. I want the post-op refraction to be plano -2 at the axis. Then after 3 months of healing, I can come back and do LASIK or PRK and dial that right in. But with a multifocal, we don't have a good multifocal option.
Dr. Neto,
Yeah.
do you want to share your presentation?
Okay, now just Okay.
There are two questions and we have to move for the next. Do you still have more presentation, Neto? Or
No, it's just
discussion?
It's very, very, very fast. I don't know if it's okay. I'm with the Zoom screen over, but over the presentation. Is it running the keynote in?
No, it's not.
Not share.
We're not sharing. So there are two questions. One is to Lukan, if the diagonal fixation doesn't cause tilt. And the question is from Milton Yogi, what is the take-home message regarding the single-piece IOL in sulcus? Because 25% of the people would implant it, and 13% doesn't have a three-piece IOL. What's your take-home message, Neto? We know that Lukan gave his take-home already, and what's yours?
I'm sorry, Wallace, I didn't hear it well.
So what is the take-home message? Should I or should I not implant?
I think one should not implant the IOL. I think the best option is to have an alternative IOL in such cases, and that's what I do. I have a complete inventory of three-piece IOLs in the room, right in the room, from 12 to 20 weight diopters, so that if something like that happens, I use. In this particular case, I was with a big gap in my inventory due to delivery problems, let's say. And I think maybe the best option in this particular case would be to just close the eye and do a secondary implant later with one of them. But as Dr. Lukan pointed out, and it's been my experience with this kind of design with 4 haptic IOLs, it's a very stable. I think the problems that arise with this kind of implant are very few, but I don't think it's the ideal situation.
Okay.
I don't know if it's running, if you're running late on time.
We are 3 minutes late. I just for if you can finish it, but I'd like to listen the opinion of Dr. Devgan and Dr. Megur about this, because Dr. Devgan wrote here in the chat, but I think it's good if everybody could listen to his opinion.
Andy, I think it's important to differentiate what type of single-piece acrylic lens it is. 2 haptics, 4 haptics. Hydrophobic, hydrophilic. In the US, the most commonly used single-piece acrylic lenses, probably 95% or more, are the 2 haptic design, like the Alcon Aquasoft or the Tecna ZC Blue or the Bauschwam and Vista, that are hydrophobic and 2 haptics. And those ones, I don't think do well with sulcus at all, so I don't encourage you to put those in. I agree with Dr. Neto, the best result here is going to be a 3-piece lens, haptics in the sulcus, and the optic captured behind the capsular rhexis. That will give you the best option. The other lenses that Lukan was describing sounds great. I like your very innovative thinking as usual, but we don't have those IOLs in the USA. We're behind our international colleagues.
What about you, Deepak?
Yeah, I must confess that I have used hydrophilic lenses to be placed in the sulcus in the past in a situation where I didn't have access to multi-piece lens at that particular moment. But given a choice, there is no doubt that the multi-piece hydrophobic acrylic lens with the thin haptics are the best options available. The 2 reasons. The hydrophilic lenses, there's no issue as far as biocompatibility is concerned. The major issue is about the sizing of the lens, which is relatively much more shorter, which is not more than 11.5 millimeter or 12 in majority of the cases. So the long-term centration is an issue. You can achieve this if you have 4 haptics and a smaller rhexis for you to get an optic capture. But other than that, it is going to be slightly difficult. So my always go-to lens would always be a multi-piece lens. In the worst case scenario, even if you don't have a lens in stock, close the eye as Dr. Neto said, and then we will put it another day.
We are 8 minutes late, but there's one question that many people asked, and that's for Lukan. Lukan, everybody's afraid that if you capture the IOL the way that you proposed, you're going to have a tilt, and the tilt always generates astigmatism, not coma though. Are you afraid of it? Are you worried about it? It's for doctor.
No, actually these lenses with 4 haptics, you achieve equal opposite capture of the optic through the anterior rhexis. So if you try this maneuver with 2 haptic C-loop lens, you are in danger to get tilt. If you have 2 haptics behind the rhexis, 2 haptics on diagonal fashion in front of the rhexis, you achieve a parallel plane to the rhexis. Of course, this is a maneuver intended for a monofocal aspheric lens, but not for example, multifocal or something that is highly dependable from the centration. In USA, you have a B&L AO lens, which is with similar design, but still it's a aspheric lens with 0 asphericity, so it can tolerate a little bit that centration.
Let's move on, Taguchi.
That's great. Dr. Uday, I'd first like to thank you again for your presence. Dr. Uday runs his most famous site, The Cataract Coach, and also his channel on YouTube. As has been observed before, he usually posts a lot of videos, and well, I have only to thank, apart from being in this meeting, for running these resources, because I am pretty sure it has helped many surgeons to get better with their techniques and feeling for Phaco overall. Dr. Uday, if you could share your screen videos.
Will do. Thank you, Felipe, Raphael, Wallace. A pleasure to be a participant in this conference. Let me send you my link. That should come up. That's the first video we're going to show. It's going to be my challenging case first. And we'll learn from that. There you go. And then let's go to share my screen. Let's see if this works. And share. There we go. So here's this case. So something's different about this white cataract. And you can see when we look, it obviously is very an intumescent white cataract. And the key here is the history. The patient had a pars plana vitrectomy 1 month prior. So filling the eye with the trypan glue, putting our viscoelastic in, this part is routine. We'll get through it quickly. Now the key in this case, of course, is the rhexis. And when we do this, we'll make our incision. Interestingly, I like to sit temporally for most of my cases. I know a lot of the other surgeons are sitting superiorly, but in the US, temporal is more common. I like it because it's further away from the visual axis, and I think it gives me better access to the anterior chamber. And then also, that's where most of these elderly patients have their astigmatism. So making the incision here, when we poke in the capsule, already it's not normal. I try to poke in it. It's actually quite difficult to poke into it. We finally get it started. Now, it's not because of weak zonules. Zonules are fine. We start our rhexis here, and notice there's no fluid coming up. So that's a good giveaway. Another thing is the anterior lens capsule is not dome-shaped. It's sunken in a little bit. So again, the key is the history. The patient had a vitrectomy just about a month prior. And I knew there was going to be a problem here when I saw the patient consultation, and I did the A scan to measure the axial length, and we'll show you that. So we get a nice looking rhexis here. Looks pretty good, appropriate size. Now certainly in this case, if you need to put a solid lens in, let's make sure we have that 5 millimeter rhexis, which we do. And then in this case, you don't need to do any hydrodissection. You don't need to do anything other than put the phaco probe in the eye, but look what happens with that infusion pressure. Suddenly starts to look a lot deeper, and then we try to aspirate, and it's all gone. It's just gone. So certainly the issue here is look at that A scan. The posterior capsule was already open, and the lens material was already leaking into the vitreous cavity at the time of my pre-op consultation. That's the issue. So during the initial vitrectomy, the posterior capsule was inadvertently violated with the vitrector. And so now, there's no chance of getting this up through the anterior segment, especially in an eye that's already had a vitrectomy. These lens material pieces fall back to the posterior segment very quickly. And so we can try clean up a little bit here. We'll clean up and put the lens in. Now, I actually knew this was going to happen, and we have our vitreoretinal colleague scrubbed into the surgery with me. I don't have the same skill sets as Lukan. Lukan does anterior, posterior, anything he'll do. That's amazing. I'm very jealous. But for me, I'm just a cataract surgeon. I don't do vitreoretinal surgery at all. And so I'll have to use my colleague who's going to help me, and he does only vitreoretinal surgery. In the US, and certainly in Los Angeles, in my part of town, it's very common for us to ultra specialize. So my private clinic is actually no general ophthalmology at all. My clinic is only cataract surgery and refractive surgery. That's it. I don't ever check your visual field test. I send you out for that. And similarly, even for an intravitreal injection, I send you to a retina colleague. So cleaning up here, now we can see this is clearly a big violated posterior capsule. This patient will do fine with a sulcus lens, optic captured behind that rexus. So here's putting a little viscoelastic to open up the ciliary sulcus. I'm going to use a 3-piece acrylic lens here, monofocal. This patient's a little myopic, and she wished to retain her myopia, which I can understand now that I'm presbyopic. So here comes the lens. Again, it's an acrylic lens. Now, the eye is obviously very soft, unicameral eye, prior vitrectomy, and we'll deliver the lens here. And sometimes I like to deliver the lens on top of the iris initially, and then dial it in exactly where I want it. So instead of delivering it directly into the sulcus, I'll deliver it here, and then I can dial in the lens and get the haptics nicely secured and tuck the optic behind the capsulorhexis. Now there's a question earlier, what do you do with the lens calculations? In this case, with the optic being captured behind the capsulorhexis, it's about the same lens calculation as regular in-the-bag implantation. If the entire lens is in the sulcus, including the optics in the sulcus, then you need to adjust the IOL power down, and that's what I call my rule of nines. 0 to 9 diopter IOL, no adjustment. 9 to 18, drop by half diopter. 18 to 27, drop by 1 diopter. And so there you go, there's the optic capture, and this will be very good for long-term stability. So you can see the rexus takes on that oval shape, or the football shape. And now we'll suture up the incision. That little bit of a lens capsular material that's behind the optic there, my retina colleague will get with the vitrector. Definitely suture the incision shut, because he's going to do a repeat part planar vitrectomy. And so cut it, bury that. And then for the vitreoretinal part, we're going to fast forward through that as well. But the usual small gauge vitrectomy. The lens material on this patient is relatively soft. It's not a very dense cataract. You can tell by the eyelashes here, this is a relatively young patient. This is not a very elderly patient. The cataract was primarily due to the vitrectomy and not from age-related neurosclerosis. So here he's making a bigger opening here, bigger cautery area, because he thought he may have to put in a larger gauge lens fragmentome. But fortunately, this will just all come out with aspiration. You can see here, again, this is my colleague operating. And so there you can see the evidence of the prior detachment and the laser that was done before. And then there's the lens material came up very quickly, very easily, and that looks pretty good. I mean, this is shot at very high rate, high speed, just so we can get through the case. The important case here, I think the very important take-home message is to pay attention to these small clues. You can tell before surgery by the history, vitrectomy, and then 1 month later, a white cataract. You can tell from the A scan, which showed the defect of the posterior capsule and the lens going in the vitreous cavity. You can tell even by the slit lamp examination, because the anterior lens capsule, instead of being domed forwards, it was sunken in. And so all these things are giveaway signs that the patient's going to have a very complicated course intraop, and you should prepare to do the vitrectomy like this. And I'm happy to say the patient did well and achieved a very nice outcome. Happy to open this up for discussion. Here's the very last end, cleaning up a little bit of those capsule fragments to make sure it's nice. Alrighty, so there's the end. Let me close that and we can go back. And I'll stop my screen sharing and open that for discussion.
We have some questions from the chat, but initially I would like to know the opinion of the other surgeons here. And there is one question that brings my attention. They're asking if 6 small incision cataract surgery, or for those who don't do it, it's an extra cut, like would have been a better option in such cases, as the chamber fluctuation, as said here in the question, is less.
Yeah, and SICS is not useful in this situation because it's a very soft nucleus and it's already partially in the vitreous cavity in a post-vitrectomy eye. Any instruments going in the eye, especially when you make this large incision here, you're going to cause some pressure and have the nucleus, whatever's left of it, fall back. This patient was young, only about 50 years old. So SICS is needlessly making a large incision in this eye where you could have removed the entire lens through 2 paracenteses with just the vitrector. If I didn't need to put an IOL in the eye, the entire lens could have been removed with just a couple of small incisions. So no, SICS, I think it'd be okay if the patient had a very dense cataract. But in this situation, I don't think it's entirely useful. There's a private message for me too. Yeah, I do a lot of other surgeries in my professor role. My week is split 50-50. Half time private clinic, only cataract refractive. Half the week I'm with my residents, where I do glaucoma surgery, cornea surgery, gosh, even rarely strabismus surgery and eyelid surgery. But I never do partial vitrectomy. So those I always farm out. I always send out.
Dr. Neto, what's your opinion?
Importance of a good capsular axis, a well-centered and ideally sized capsular axis really gave the possibility of a good outcome, because with the sulcus implantation and optic capture of the IOL, you get a stable IOL centered and with that's a hard one, compartmentalizing the eye. And so in these cases, I think you cannot stress too much the importance of a good capsular axis so that it can save you afterwards.
Excellent point. There's another question about what type of anesthesia. So by normal cases, every case is topical tetracaine, a little bit of preservative-free lidocaine inside the anterior chamber. That's it. And systemically in the IV, they give 1 or 2 milligrams of midazolam, which is Versed. In this case, we knew there was going to be an issue. And my retina colleague was in the OR with me. So we did a retrobulbar block at the beginning of this case, because we knew ahead of time. If you're in a situation where you're doing the cataract under topical and you know there's a posterior capsule rupture or complication and you need to do an anterior vitrectomy, I tell my residents to add more anesthesia. That's a good time to get a retrobulbar going on the field, on the sterile field. Very important to make the patient comfortable.
Deepak,
Dr. his hand as well.
Dr. Uday, I think that was wonderful exhibition of a case where how to anticipate a situation. I think I agree with you that A scan gives a lot of clues. My one addition would be like whenever we see an intumescent lens or a white lens where the convexity of the capsule is lost, when we look at the antechamber depth, that also gives us a clue. Invariably, I see whether it's because of trauma, the capsule, posterior capsule is open, or a post-vitrectomy state, the antechamber depth invariably be more than 3.5. So when we look closely at the antechamber depth in the A scan, if it is more than 3.5, that is an indirect evidence or it is a sign of caution for us to anticipate a pre-existing posterior capsular tear. Wonderful tips, Dr. Uday.
Excellent comment. I didn't bring that up, but you are correct. Thank you for teaching me. But it makes sense. If the AC is deep, 4 millimeters deep, like in this case, it's because of this situation. All right, let's go to my routine case. I'm going to pull this one up next.
Can I comment a little bit?
Sure. Yeah.
I want to comment this from both points of view, like from a vitreoretinal surgeon one and from cataract surgeon one. For example, we here, when we do retinal surgery, we always remove the lens because of this situation, because the retinal surgeon can damage the posterior capsule and the cataract surgeon after him to have issues like this one. The good thing was that you have your backup plan, you have perfect rhexis, and you have even your vitreoretinal surgeon in the OR. The good thing is, and the take-home message is to know the habits and the way of dealing of your vitreoretinal surgeon. Because, for example, I don't use fragmaton. I rise the nucleus with PFCL to AC and then I emulsify it with the Phaco emulsifier. So, in that scenario, the referring surgeon should not implant the lens. And if your vitreoretinal surgeon uses a fragmaton, you completely do the right thing because you compartmentalize the eye and you avoid additional issues if vitreous remnants are present there.
Excellent points, Lukan. Excellent.
There are some more questions here. They're asking if, as the cortical matter was already liquefied, could it be managed by steroids later?
You're already there. You already have small gauge bimanual instruments. Just remove it.
Okay.
Keep the patient happy. Already the patient had to have another surgery that she wasn't anticipating. So.
And did you see the biometry before or after the surgery?
Before. I did the A scan with my own hands.
And you already told the patient that he or she might have a PC rupture.
Correct. And I also told the patient that we're going to have your vitreoretinal surgeon and we will do the surgery together.
Yeah, I think that's the point to anticipate and tell the patient everything that may happen. I think it's a good thing, right?
Correct. All right. In the interest of time, we're going to make this next video fast, and I'm going to catch up. We'll finish right on time. Here is the link. Oh, let me send this to everyone. Send link to everyone in meeting. There's that link. I think that went through. Try one more. There we go. And let me share my screen. All right. So this is just a routine case. What was different here is this is a fellow ophthalmologist, a fellow cataract surgeon, no less. So the stress here is not actually performing the surgery, it's me, it's the mental stress in doing the case. And this is pretty much a routine, average, normal case for me. Now, fortunately, this is just posterior subcapsular. This is not a posterior polar. If my fellow colleague from down the street had a posterior polar, it'd make it even more stressful. So I start off by putting in preservative-free lidocaine. So this is 1% lidocaine preservative-free, but 50-50 with balanced salt solution. So it ends up being 0.5%. Here's the dispersive viscoelastic. This is visco in this eye, getting a nice good wave and a good coating of the endothelium. I like diamond blades a lot. And so here's a diamond. We're using a 2.8 at the tip keratome. This patient has a little bit of sill at this steep axis where we're operating, which is against the rule. And then now, of course, you saw Dr. Neto also use similar forceps. A lot of us have these forceps that have marks on them, 2.5 and 5 millimeters, which is, of course, the radius and the diameter of the ideal rhexis. So here we're going to try for about a 5 to 5.5 millimeter capsular rhexis. And again, anesthesia here is just topical with a little bit of intracameral lidocaine, as well as IV anesthesia, intravenous, 1 or 2 milligrams per cent. So there's the rhexis, and that looks pretty good. Notice the blood from the incisions. I like that. I like to barely nick the limbal vessels. That means great long-term stability and healing. So here's the hiatal dissection, nice and gentle, watching for the fluid waves to go around. And one of the nice things about operating on a fellow ophthalmologist is lens calculations are very easy. All you do is you ask the patient, what do you want? And that way, he can't blame you later if it ends up being off a little bit. But here's the rotation. Now, only a very little bit of rotation. I am going to try Dr. Rosatelli's spin technique as soon as we finish this virus stuff and I get back to the operating room. But I would love to learn that technique. I'm going to try that. But here's just a little bit of hiatal dissection, a little bit of rotation. And here's the Phaco tip. And again, we're using the purple sleeve because it's a 2.8 incision. And we made a 2.8 incision because the patient still is... Okay, let's finish this first. I'll give the questions at the end. So we'll go in here, chopped it in half. And you can see it's not a very dense cataract. Of course, if you yourself are an ophthalmologist, you probably won't wait until you have a renescent or dense cataract. You'll probably want surgery sooner. So these pieces come up pretty easily. Not much issue there. Nice and soft. The key, of course, is let's not damage that posterior capsule. So using that second hand, the chopper to really bring the pieces up. Again, not a difficult case. The stress for me is mostly mental. The patient was one of my mentors who taught me cataract surgery 20 years before. And so I had to be very careful. And so we'll take out our cataract pieces here, finishing this up nicely. And look at the chopper position. That's protecting the posterior capsule just in case. Take the instrument side of the eye and we'll clean up here. The surgeon here wanted just a monofocal lens, aiming for, I believe, a little bit of myopia, which I'm very happy for me to be myopic now because of presbyopia. So cortex removal, let's speed this up a little faster. The rest of the case is pretty normal. So, and at the end here, monofocal lens, gonna go in the bag, polish the capsule, not going overboard. And the surgeon also, by the way, he said, at the end of the surgery, I want a copy of the video. So, when I need my cataract surgery, I'm coming down to Brazil, though. And then here's removing viscoelastic. We planted the eye well with viscoelastic, with a cohesive viscoelastic in the eye. And so you have to go behind the eye well to remove it. And we can see the lens is nicely centered up, seal the incision. I do a very minimal amount of stromal corneal hydration. And then I sweep the angle with VSS, make sure there's no retained viscoelastic. So let's end that sharing. And let's go back. We're going to have a very brief discussion, but I want to catch us up on time.
Dr. Deepak, do you want to hear?
Yeah, we can move to Dr. Deepak. I want to thank you guys. It's a really big honor for me. first time I went to Brazil, and by the way, on the advertisement you sent out for the meeting, thank you for using my old picture from 15 years ago. I look much younger, thinner, no gray hair, more hair. But the first time I went to Brazil, that was the photo. It was 15 years ago. I was invited by Dr. Milton Yogi, and we had a fantastic time. And ever since then, I've always been very proud of my Brazilian colleagues, and I've learned a lot from you guys.
We should thank you a lot for having time to be with us here. It is a pleasure, and we all hope that soon all this lockout ends. We will all meet in person, and we will cheer for our health. Thank you very much for your help. Any other question, Taguchi, that we should ask him on the chat?
And by the way, I'm still making videos. A lot of people have emailed me asking me why are there no YouTube links, no new ones? I actually post the videos to YouTube in big batches, 10, 20 videos at a time, and then every day on cataractcoach.com I release one video. So if you're watching them on YouTube directly, you're very smart. You're studying before the lesson.
That's great. For our next videos, I would call Dr. Lukan if it is okay for Lukan and Deepak.
Yeah, Lukan can go ahead, no problem.
Okay. Just a
And
second.
while we are switching, Dr. Deepak would like to comment on Dr. Uday's technique.
I just saw it was a wonderful demonstration. The stress he demonstrated was more, I think, just to keep us in good spirits. I think he did a wonderful job. Thank you, Uday, for sharing your videos on YouTube. A lot to learn from you. Thank you.
This is my video. Is it already shared? Do you see it?
Yes.
Yes, we see it.
Okay, before I start, I can only add that if you subscribe to Dr. Uday's channel, you will have a notification for every new video, and you can catch up with the production, because this is like Hollywood. Perfect. This is a regular case. Is it okay? You see it? Yeah. I normally do a 2 paracentesis, and I like to use cohesive viscoelastic, which I put in the eye before I make the corneal incision, because now the eye is firm, and the incision, I think, is more good and well formed. I use 2.2 keraton, limbo incision. This is the rexis, and this is a regular cortical cataract. So everyday surgery. The plan is to use monofocal single piece acrylic IOL from BNL, which is IDEA. I don't know if you know that model. And it is pretty good for hydroimplantation. Now I like to do the hydrodissection through the main incision. That way viscoelastic can escape, and I do not create over pressure in the AC. I'm using a balance tip from Centurion, but on Constellation machine. My technique is like opposite chop. It is a modification of the horizontal chop, and I like to reach under the capsule and to chop the pieces with actually less vacuum and fluidics energy, because my settings are like vacuum 280, flow rate fixed 14, and 100 millimeters of bottle height. I use only torsional without longitudinal, and this is the surgery. I divide normally on 4 pieces and then chop them piece by piece and eat them like that. I like low fluidics settings because the total amount of fluid which pass through the eye is less, and on the next day the cornea is clear. Now this is the end of the emulsification. I use bimanual INA because I think the control is better, and I can reach every spot in the anterior chamber, especially under the main incision, which is sometimes difficult with coaxial irrigation aspiration. I like to have flat aspiration, that way I cannot unintentionally grab the capsule, especially the posterior one. This is the cortex coming out. And now the implantation. As Dr. Neto showed the technique, it's fairly simple. There is really less viscoelastic in the AC. And now hydration of the wounds. So that's it, my first case, regular surgery.
Dr. Lukan,
Yes?
is that IOL the one you mentioned you could cut the haptics?
No, this is not the one. I meant a plate haptic lens, which is from oculate
Okay.
lenses. Yeah, yeah. So
Beautiful surgery, Lukan.
thank you, Professor Devgan.
Dr. Neto, would you like?
I think this is the first time I see someone do placing OVD before the corneal incision. And I like the comment of Dr. Uday saying that he likes the blood. It reminds me of my partner and the excellent surgeon, Dr. Edson Mori. He likes the blood too.
Just a little bit. If the incision is 100% avascular, then it's like a LASIK flap. 10 years later, you could just open it right up.
What I would add is that I concur with Dr. Uday that I'm really envy of Dr. Lukan for being also a posterior segment surgeon. I think that must give him a really great peace of mind. I really would like to be one. Excellent case and surgery. Congratulations, Lukan. Very beautiful surgery. And I eagerly follow your channel.
Dr. Lukan, people from the chat are asking, what chopper do you use?
The chopper actually is my design, created 1 year ago, and there is my friends from the audience now. One is Professor Milton Yogi, the other one is Gustavo Huning, which have experience, real life experience with this chopper because I sent it to them, and probably they can share some thoughts about it. I like it because it's safe and I can reach everywhere, and as you noticed, I am I'm not paying attention where I'm going with the chopper because the tip is not harmful for the capsule. Can we bring Professor Yogi to comment of if it is here?
Sure, Milton. Would you like to comment? And Gustavo also. Gustavo just wrote on the chat saying that the chopper is great.
Dr. Milton, I think you're muted. I think your mic isn't working. Hello? Dr. Gustavo? Hello?
Professor Milton, before, please.
I think he has some mic issues, if you would like to start.
Okay, so good morning, everyone. Thank you for the space and congratulations for the organization. It's outstanding, just great surgeons. You are all my inspiration, guys. To be very brief, Dr. Mishev chopper is amazing, and the greatest thing about it, in my opinion, it is because it has no sharp sides. It's really difficult to have a posterior capsule rupture with it while you're doing your Phaco, okay? And if you're able to put it on the equator, you're gonna chop it really, really easy. I do recommend it, and I don't know if he's already selling them. I tried to buy them, but he didn't let me. I strongly recommend it. Good luck, guys. Nice talk.
Are you listening to me now?
Yes.
Yes.
Okay.
Yes.
I'm very happy to chime in. Congratulations, Lukan. I want to tell my colleagues that Lukan is a geek, Phaco nerd. He tries with technology. He's a uber geek. He uses professional cameras, cinematography cameras in order to record his videos. I used to talk to him about these aspects, and I learned from him. The other aspect he is very knowledgeable about is the premium IOLs that are offered in Europe, and we don't have access to these platforms in Americas, so I learned a lot from him. And regarding the chopper, I had the opportunity to use it when he was in his early prototypes, and it's a very, very clever design, as Gustavo stressed it out. It has an angled tip, and it has a very polished design, so it offers no danger to posterior capsule, and I use it a lot. I think mine was produced by Epsilon, but I don't know currently how it is in the market, if it's the same manufacturer.
Thank you, Milton. It's always a pleasure having you here. I put a poll here just to help us to know where you're coming from. But while the poll is going on, I would like to ask Lukan to show his second video, please.
Thank you.
So, is it on the screen now?
Yes.
Okay, this is a case of posterior power cataract, which I approached routinely, and the idea was to implant EDOF lens called Synthesis Plus, which is for haptic design, and when I anticipate some incident with the posterior capsule, I choose for haptic design lens because I can diagonally fix it to the anterior axis. So Here, again, routine rhexis. And I think the key thing with posterior power cataracts is to have a good anterior rhexis. As Dr. Neto pointed out, this can save the day later if we have issues with the capsule. Now, opposed to the common opinion, I do like to make gentle hydrodissection, not hydrodelineation, because I think that there is no more gentle thing than the thin fluid wave to dissect around or to dissect the posterior plate. In my opinion, 90% of the posterior power cataracts, they're between the posterior plane and often are not attached to the immature posterior capsule. So if one is careful enough, it can be really done well. Now, the other thing is that I don't rotate at all after the gentle hydrodissection, because the rotation can open up the thin capsule, because the pressure that we can induce with the chopper can open it up. Again, low vacuum settings, avoiding fluid waves and high pressure in the AC. And obviously this is really soft lens. Now again bimanual INA. In this particular case, and in our normal practice, we use only topical anesthesia and intravenous sedation. But here the patient is a little bit tense. Now I will try to peel that plaque there. Here you can see how the patient moves. So in such cases, the presence of anesthesiologists is priceless. Now, after cleaning the periphery, I will try to peel that posterior plaque.
This is where my heart beats very fast.
Mine too. Now here you see the opening of the posterior capsule, where I realized that I should do something more than just implant the lens. Now I will go out only with the aspiration and ask my colleague to bring me the cohesive viscous syringe. I will fill the AC and then I will go out, because the situation turns like in child case, how we can perform a posterior rhexis. I put cohesive viscoelastic in Berger space to delineate the vitreous from the capsule, and I decided to create posterior opening of the capsule. Methyl cellulose over the cornea for for better visualization and for taking a few breaths, because entering the eye. Here normally my heart stops beating.
Dr. Lukan, do you have any comments on how to do a posterior rhexis? Because it's quite different from the anterior, right?
Yeah, I think the most important thing is that you do not need to overfill the anterior chamber and to overstretch the capsule with OVD. So you aim for firm eye, do not overfill it, because it will alter the direction of the rhexis. So this is my posterior rhexis. Here it's fairly centered. Now I will put additional viscoelastic before the implantation to open the capsule. It is really important the surgeon to load the lens now, because any issues with loading will compromise the end result. And to control the loading under microscope, to be sure that everything is fine. Now I like to place the spatula under the lens in order to prevent engaging the posterior hole of the capsule. This is the synthesis EDOF lens. 4 haptics. Now when I implant it in the back, you will see how one mark of the lens engaged the posterior rhexis. Another critical moment for my heart. And I was surprised that with a gentle spatula movement I can relieve that without causing tearing of the posterior rhexis. So this is the end result. This is the irrigation aspiration. The important thing to note here is to reduce the bottle height, because if you observe carefully, there will be 2 moments where all the diaphragm pops back, like increased pressure inside the eye. Here it is. So reduced fluidics, no vitreous lost, well-centered lens.
Beautiful surgery, and now the patient will never need a YAG capsulotomy.
Indeed, yes. And this is the end of the case.
Dr. Lukan, we have some questions from the chat.
Yeah.
First of all, beautiful surgery, congratulations. And they're asking if, do you try viscodissecting these cases as well? And if, in this case in particular, there wasn't any signs of posterior capsular rupture before the surgery, but if you think there is a rupture before the surgery, would you even then try to gently manipulate or gently hydrodesiccate or viscodesiccate these kind of nucleus?
In my personal experience and opinion, I would only use gentle fluid wave, because viscoelastic, no matter dispersive or cohesive, it increases the volume a lot. And to answer the question, I would not do viscodissection in such case. On the second question, probably, as you pointed out, I'm privileged to be a pole-to-pole surgeon. So for me, it doesn't matter if the posterior capsule opens up, I will deal it with the posterior way. But the most important thing in such cases is to make a good capsulorhexis to save your day later.
Great. That was wonderful exhibition of the surgery, and also you did the posterior capsulorhexis really well. One small query: would you prefer a dispersive OVD or a cohesive OVD to inject under the posterior capsule in the burger space? What's your choice of OVD just before doing the rhexis?
I always use cohesive OVD because I need space maintenance, not covering the tissues. I need to open the space, and I didn't saw any IUP late issues with leaving the cohesive OVD in the posterior chamber or behind the capsule.
Great.
So, Dr. Devgan, you're going to have your cataract done here. I'm going to Bulgaria.
I'm going to do one eye in Brazil and one eye in Bulgaria.
And then we'll go to India.
Can I go to Brazil and we all go there and resolve the case?
Okay.
Dr. Lukan, there are two more questions here from the chat. Do you always, I don't like this word as always, but do you usually polish the posterior capsule in these cases, and also when do you leave, if ever, these cases for iliac capsulectomy after?
In this particular case, the white plaque was significant, and the lens which was chosen here is EDOF, so it's a little bit surgery that requires good outcome. Or I wouldn't advise on every case like this to make a posterior rhexis if we know that with iliac laser we can handle that. You know the rule, primum non nocere. If you are not sure that you will going to make successful posterior capsulorhexis, leave it to the iliac laser.
And do you aspirate the viscoelastic behind the IOL?
No. In this condition, I'm afraid to go back, because if you pull the anterior hyoid, it will mess all the efforts.
Great, nice surgery. I think we can move on. Are there any other questions? Dr. Hommel is asking if you have some tips for red heart cataract associated with a posterior polar. That's usually found only.
Red heart cataracts. Yes, I think he implies to this type of cataracts where they have function like 0.4 or 5, and when you touch the nucleus it is like brunescent cataract. Actually, my only advice is to have a vitreoretinal surgeon near you, or to have a good friend near a vitreoretinal surgeon.
Or being a good retinal surgeon as well.
If you be, yeah.
Congratulations once again, Dr. Lukan.
Thank you.
Dr. Deepak, would you like to share your views? Dr. Deepak is a great friend from India, brilliant surgeon. I think you're muted, Dr. Deepak.
Sorry. Yeah, I'm
Maybe
on.
try to share your screen, so if the video gets too choppy, Rafael is ready to reproduce it if needed.
So I'll be sharing a case which I experienced about a few years back. It was 2017. I think this case is I'm starting it just after Dr. Lukan's post-polar cataract, because my case also is the same. This is a case, the experience which I have never seen in my hands, and I have never seen with anybody else so far. So it was a great learning experience. Most complications do teach us more than the routine ones. So I'm sharing the case which I had a complication which was first of its kind for me. So just let's go through the video, and this video has the audio also. So training and education. If there's any issues, please let me know.
Just think, your screen isn't shared, Dr. Lee.
Just a second. Is it shared now?
Yes.
Okay.
Your discretion is strongly recommended.
So this was back in 2017. We had this experience, and the title is "How Early Can a PC Tear Happen?" And this was a unique experience for me. I didn't see anything like this before. I'm not sure whether you have. Just let's have a look at this case.
This male patient was having postcerebral cataract. He has a classical onion peel appearance, and interestingly, the biometry shows a very deep chamber of 4.62 millimeters and an axial length of 26 millimeters. So let's begin the case. The surgery is being done under post-subcutaneous anesthesia. So after making the two side port incisions, I stain the empty capsule, and I'm using initially dispersive OVD followed by cohesive OVD for the classical soft shell technique. And as I'm introducing the OVD, I suddenly see something unusual happening here. When we go back and see the replay, the posterior plaque just expanded during the injection of the OVD. This was something very unusual and clearly suggestive of a potentially an open posterior capsule now. So my plan was to assume that the posterior capsule was ruptured, although it was not very clearly evident, and all my subsequent strategies has to be taken with this consideration. So the rexus sizing and centration was the most important thing, because I would want to have an optic capture, because the PC was probably be defective in this case. So I'm aiming at a well-centered 4.5 to 5 millimeter rexus, which could be achieved quite easily. I'm not performing any hydrodissection. I'm using a blunt eye spatula to perform a sort of an hydro-free dissection. And then I directly proceed to sculpt the central nucleus using very low flow rate, low bottle height, and low vacuum, low power. My idea is to perform an inside-out hydrodelineation, as has been popularized by Dr. Vasavada. Once I achieve the hydrodelineation ring, I'm separating the two heminucleus, and without any rotation of any of the fragments, each of these fragments is emulsified using the slow motion technique, as has been described by Dr. Osher, using low parameters, low bottle height, and a low power. The emulsification nucleus is not at all an issue here, because it's extremely soft, and each of the two heminucleus pieces are emulsified. Now, before I'm trying to engage the epinucleus and trying to consume the epinucleus, but the small size of rexus is restricting the easy accessibility of this epinucleus. Once I've trimmed the distal part of the epinucleus, before removing my Phaco handpiece, to prevent AC from shallow, I'm introducing another handpiece with irrigating fluid so that the chamber is maintained throughout. Now I'm using dispersive OVD. The idea is to perform viscodissection so that the epinucleus is pushed into the pupillary plane, and at the same time the dispersive OVD also provides a sort of a barrier and a tamponating effect for the postcapsular tear, which is presumably present behind. As I'm aspirating the cortex, the first time I noticed the the possibility of a PC tear here. I can see a defect which looks very much like a post-capsule defect. And again, at this moment, I stop the procedure and go back and inject dispersive OVD just to ensure that the defect is adequately plugged by the dispersive OVD. At the same time, the epinucleus is pushed a little bit more anteriorly. Again, the wide split in the posterior capsule is very much evident, and again I go back, use my dispersive OVD to plug it, and once it is done, the remaining part of the epinucleus is gently maneuvered into the pupillary zone and again aspirated by my Phaco handpiece. And there's no vitreous prolapse at this moment. I need to go back and remove a little bit of the cortex which is there. Again, the cortex is being aspirated using extremely low bottle height and low parameters. Care is taken that there is no fluctuation in the antechamber. Once all the cortex is removed, I'm wondering whether to do antivitrectomy or not, because at present, the antihalide phase doesn't seem to be disturbed. But however, I see few of the lens fibers in the antivitreous, so I decide to go ahead and perform a limited bimanual antivitrectomy. After just doing a limited antivitrectomy, clear off a little bit of the lens debris which were there. The plan is to put a multi-piece lens into the sulcus. This is a hydrophobic acrylic multi-piece lens, and we're placing the sulcus. The lens is then gently dialed. Now I go again with my retractor to remove the OVD which is gone behind the lens into the vitreous cavity. Once the OVD behind the lens is in my left hand, I gently nudge the optic behind the rhexis margin using the lens dialer. The rhexis becomes oval. The ovalization of the rhexis is an indicator of the perfect optic capture which has been achieved with the haptic spinning sulcus and optic behind the rhexis margin. I'm confirming the absence of vitreous by using a transphenosteate for one last time. Diluted pilocarpine is used to conceal the pupil, and eventually the case did well. These are the eye looks post-operatively. On dilated examination, we can clearly see that the lens is extremely well centered and is well trapped behind the rhexis margin. So what did we learn from this case? This case demonstrated a very rare phenomenon of rupture of the posterior capsule in a case of posterior polar cataract because of increased hydrostatic pressure inside the eye, even before the rhexis could be performed. Lessons to learn here is that although maintaining an antechamber depth is critical, overinflating the chamber can be deleterious to the pathological posterior capsule in a posterior polar cataract. Maintaining the antechamber equilibrium throughout the procedure is critical. However, over-deepening or sudden shallowing are to be avoided in such eyes.
I think that's it.
Beautiful recovery. I have never seen a case like that in my entire life.
Yeah.
Beautiful outcome.
Thank you.
So let's ask any other surgeon, have you ever experienced something like that? Like seeing it rupture live, right?
Even before the rhexis is completed.
Yeah.
Dr. Newton pointed out in the chat that the parameters that were used, it requires a lot of effort to adjust these parameters so everything can be done perfectly as you showed in the video. I would ask which Phaco machine were you using and at what parameters?
I was using Infinity when I was operating on this case. I did use a bottle height of about say 70 centimeters when I was operating for nucleus management. But now my understanding is such that I would prefer still lower bottle height. even if you're using a gravity-based machine, not like the Centurion where it is the fluid is active, still I think lowering the infusion is an extremely important step when you're managing posterior polar cataracts, especially in younger patients and patients who are myopes. The reason I'm saying is, whenever these young patients are myopes, the scleral rigidity is a factor. It stretches, and that's the reason why there's no way the fluid comes out. That is the reason why the posterior capsular tear happened here in the first instance. The patient was a myope, although he was a 50-year-old myope, but it could happen only because the scleral rigidity or lack of it causes excessive accumulation of fluid. It doesn't go out, and that's the reason we have a raise in the hydrostatic pressure inside the eye. That's the reason why the weak posterior capsule gives way. Even in situation where we have a posterior capsular tear and we don't yet have an antihyaloid tear, the reason how we can prevent an antihyaloid rupture is if we can maintain the chamber pressure to a lower level, and at the same time not sacrificing the fluctuation of chamber. The chamber has to be rock solid, but doesn't mean it has to be very deep. So overinflating the chamber can also rupture an intact antihyaloid. So if we can understand this basic principle of maintaining the chamber rather than over pressurizing it or unduly shallowing it, maintaining a status quo like in respect to the posterior capsule or the antihyaloid, most of the time we can get away without rupturing the antihyaloid even in presence of a posterior capsular tear. As we saw in this case, the antihyaloid had not ruptured. Given a chance now, if I had to operate today, I would not have ventured doing an antivitrectomy. I would have left the OVD and a little bits of lens matter there. I would have just put a lens and come out. So it's in hindsight. In hindsight, always the things are much more clearer. But given a second chance, how would I have done differently was this. And obviously, this was a case where overinflating an eye, especially in an eye which has got a pathological posterior capsule, in younger patients and in myopes, shouldn't be done. Okay, you always err on the eye being slightly softer or on normal side rather than keeping a harder eye. It's not justifiable to keep a slightly over-pressurized eye in these vulnerable cases.
Great. There's another question here about the orientation of the haptics. When you have a posterior capsular rupture, where is, or if is there one position for the haptics to go? Either if you choose, I think we can expand this question, so for like single piece IOLs in the bag or for 3-piece IOLs in the sulcus, is there a preferential positioning of these haptics?
If you have a posterior capsular tear, and I think the first choice always is going to be a multi-piece lens, in this case, the sizing of the rhexis is important. We want to lock the lens into the rhexis. So if you are able to get a good lock in of the lens, if you have a right-sized rhexis, I don't think the orientation of the haptics matters. What is critical here is you want to ensure that the optic is behind the rhexis so that it is locked, and this ensures a long-term centration. Now coming, you want to place a lens inside the bag. Well, if a single piece lens, the question probably is indicated that what you do when you are dealing with an extra large bag as in myopes. So maybe in those situations, I would prefer to place it in horizontal meridian just to ensure that that is slightly longer. That is the reason why. But in the case of a posterior capsular tear and you're putting a lens in the sulcus, I think the sizing of the rhexis is very critical so that we have 360 degrees of optic capture. That is very critical.
That's the last question here from the chat. If this case faces a surgeon of short experience, what would be your advice?
Well, it's a tough question because this was my first experience. I hadn't had any experience like this. But I think, you need to be, first important thing is you need to diagnose the PC tear early. Most inexperienced surgeons, I doubt whether they would have diagnosed this PC tear as early. They would have just overlooked it. That is the first impression if I had done 10 years back, I would have overlooked that PC tear wouldn't be visible for me. So I couldn't have formulated anything. So you just go ahead and you do the routine surgery and the lens would have dropped. So the first thing I think would be the critical thing would be to diagnose the PC tear early. mind you, with an underlying nucleus, it's extremely difficult to diagnose a PC tape unless and until you are very focused in anticipating these things. If you are able to diagnose it, then if you have a backup support, if you're a beginner surgeon, if you have a backup support, I definitely would recommend to just have a backup. And if you have already diagnosed it, it all depends upon your experience and skill level and your anticipation of the problem.
Can I comment also?
Dr. Neto would like to make a comment.
Yes, one of the aspects I see in your surgery, the superb surgery, is what I call an elegance. The elegance of mastering the parameters beforehand. One has to have a great knowledge of the reaction of the equipment. So it's very interesting that you are also aware of this, because you showed your parameters in the video as well, just to stress out how important are the perfect adjustments of the parameters in order to do what you want to do. So many surgeons are reactive more than proactive. They go by trial and error. So they enter the eye, they do some maneuver, and then see the reaction that happens with that fluidics, for example. But you do the opposite. You adjust your parameters and understand what the reaction will be. And then you enter the eye and the things start happening as you have planned. So this kind of knowledge in terms of dealing with parameters is what I think is ultimately the elegance. Congratulations.
Thank you so much for your kind words, sir. And I think we need to remember that there is nothing like one size fits all. You need to be well versed with knowing your machine and to adjust your parameters as the situation demands. Because and the mind has to be trained to anticipate problems and be ready. Because whenever we have an unexpected complication, the stress level ensures that our efficiency level goes down dramatically. So we are not in a position to take proper decisions. So unless and until we are mentally prepared, and it's like an exercise. You exercise yourself to be ready to face the worst case scenarios. And if you are mentally prepared and well aware of the circumstances, then probably you can fine tune it. Otherwise, it becomes, in a panic situation, things can go really spiral down.
Great. Dr. Deepak, may we move on for your next case? And while we're doing it, there are some questions also from the chat. One of them is, why didn't you position the IOL haptics perpendicular to the rupture direction?
Since the lens was being placed, the haptics are in the sulcus, and only the optic is going behind the rhexis margin. So it is immaterial where you want to orient. Unless and until you want to place the lens inside the bag, that's the situation where you are going to orient the haptics perpendicular to your direction of the PC tape. And because the equatorial tear was equator to equator, I wasn't interested in placing the lens in the bag. So the idea was placing the lens in the sulcus and then achieving an optic capture. So in this scenario, orientation of the haptic doesn't matter so much.
Great. Could you share your next video, please, Dr. Deepak?
Can I comment during the transition?
Hello, I will present this case which demonstrates the routine steps on my way of doing cataract surgery. This is a 90-year-old lady with a dense cataract. The surgery is being done under topical anesthesia with some amount of supplementation using subconjunctival laser. After making the side ports, I was steaming with trypan blue. Visualization is challenging these brown and black cataracts as there is limited contrast. I'm using dispersive OVD, which is a mix of chondrite and sulfate and sodium halides. The main 2.8mm incision is created by stabilizing the globe with the second instrument to the side and 2.8mm barrel of sharp keratin. My preferred incision is always a posterior limbal incision, as I find them safer, faster treatment. Moving on to rhexis, I'm using forceps to do the rhexis. In such cases where the nucleus is hard and bulky, I aim to perform rhexis which is not less than 5 mm. Having an adequately large rhexis makes life relatively easier during nucleus division and management. Once the rhexis is done, hydrodissection is performed with the bare minimum amount of blood, followed by decompression to let out the trapped fluid. The nucleus is gently rotated to ensure that there are no corticocapsular adhesions. My strategy for nucleus management is to do a direct chop for this case. Before starting, I prefer to make a small central trench so that I can bury my phaco tip in a much deeper plane and I can get a firmer grip. I prefer to stabilize the nucleus with my chopper during trenching. I aim to perform a trench which is about 60% deep. Now I switch to my phaco chop settings. I'm just using longitudinal power in burst mode. I'm burying the tip into the nucleus until the entire tip is submerged into the substance of the nucleus. Then the sharp chopper moves down vertically and then laterally. The lateral separation maneuvers will be repeated at progressively deeper planes so that as the scissor blades are cataract. Once the posterior plate is cracked, I move on to create the next chop. Again, similar maneuvers, bury, vertical chop, and then lateral separation. Now, for a moment, let me talk about my settings. During chopping maneuvers, I don't use torsional ultrasound. I prefer longitudinal only because we get better hold and grip, which is critical for chopping. And because torsional has excellent cutting ability, I use it during the quadrant removal and sculpting. After the third chop, I'm getting one of the quadrant out of the bag and then consuming it. The idea is to create some space in the bag, which is helpful in such cases in which the nucleus invariably would be large and bulky. The chopping is continued in a similar fashion until I have many smaller fragments which are easier to consume. One of the primary concerns while dealing with such cases is the corneal endothelium. Two factors are critical which predict the amount of endothelial damage during emulsification. The amount of turbulence generated inside the interchamber and also the plane of emulsification. These are the two critical factors which decide how clear the cornea is going to be on the first post-op day. It's mandatory for us to ensure the plane of emulsification is at the level of rhexis or the level of the iris. To control turbulence, we must always have just the right amount of power coupled with the appropriate flow rate and vacuum for that particular machine so that all the small fragments are emulsified in a very controlled manner without any of the fragments flying around and hitting the endothelium. So one prerequisite would be to use adequate amount of appropriate OVD. I prefer to use the dispersive OVD on top followed by HPMC underneath. It is some sort of a modified soft shell technique, if I may call it so. Dispersive OVDs like the viscoat, etc. can be thermogenic. That is, it can produce a lot of heat. I prefer to place it much near the endothelium, and methyl cellulose is placed under it, that is, at the level of the rhexis and into the capsule bag, which is where the phaco tip would be and the heat would be generated. So finally, the last fragment is emulsifying. Wound burn will also be a concern, but not so much with torsional though, but I usually ask my assistant to keep pouring BSS on the region of the incision. The cortex is then aspirated out. Finally, it's time for the lens to be implanted. I'm I'm using the hydroimplantation technique to place the lens into the bag in this case. The remaining OVD is removed, side ports are hydrated carefully. The elderly people are vulnerable for breast cancer attachment, so we need to be aware of that and be a little bit cautious during hydration. That's it. Thank you for your attention.
I think that's it. My case is done.
That's great, Dr. Deepak. There's Dr. Ahmed has raised his hand. Would you like to make a question, Dr. Ahmed? Or was it unintentional also?
No, it's intentional. Thank you very much for your video and sharing the ideas. This kind of cataract with dense cataract are very common in our local area in the Middle East. And I definitely will not recommend to do phacoemulsification using the Infinity machine. I do recommend using a Centurion or Ferrous machine for such high dense cataract because of the post-operative corneal edema. And also do advise to use a 3% sodium hyaluronate for the better endothelial protection. Thank you, sir.
Thank you. Thank you for your suggestions.
I'd like to hear the comments of the other speakers. I know Rosatelli is also very experienced in very dense cataracts, and I'm sure all of you are. Let's learn.
Well, a masterful management of this challenging case, Dr. Deepak. I would like to call attention that these cases, it's very important to maintain OVD protection of the endothelium as he did. And one of the things that can help the surgeon to evaluate when to refill the anterior chamber, stop emulsifying the nucleus and refill the anterior chamber, is the sentinel bubble sign. And if you have small bubbles just lying under the endothelium, you can sort of have a good idea if there is OVD lavage happening by the behavior of these bubbles. And when these bubbles are washed out, it can be a sign that the OVD is also being washed out, and you should stop and refill. And in the surgery, I could observe that, and Dr. Deepak really refilled the anterior chamber at the exact time when this happened. And this can be very helpful to beginner surgeons to evaluate if there is too much OVD being washed out from the anterior chamber. And once again, Dr. Deepak Megur showed his masterful management of phaco parameters in this surgery.
Thank you.
Can I comment?
The OVD use cannot be, overemphasized, because at every stage we need to remember that the corneal endothelial cells are priceless, and no amount of expenditure spent on OVD can be, justified. So don't be hesitant to use OVD. I think they really are lifesavers for us in such situations.
Deepak, beautiful surgery. I liked it very much. My favorite part of your surgery was making the initial trench at the beginning in order to get the phaco probe deeper within the nucleus before you chop. That was masterful.
Thank you. I just going back to your comment on liking a little bit of blood. My incision, as you saw, is much more beyond the limbus actually. So it's almost, you can say, a little bit of a scleral type. Especially people who are using longitudinal only phaco energy, it's better to err slightly on the scleral side, because sclera is much more forgiving than cornea as far as the cornea burns are concerned. So my incision is always posterior limbal, immaterial of whether I'm doing a soft cataract or a hard cataract. But in generally, whenever we have a posterior limbal incisions, they heal much faster, the patients are much comfortable. So that is my go-to incision. In the surgery, when you're doing surgery, it may look very less elegant, a lot of blood coming out and all, but still, at the end of the day, it's still my go-to incision in all my cases.
Great. There's a question from the chat. Dr. Deepak, is there any situation that you don't do hydrodissection on these brown hard nuclei?
Thank you for the question. I think it's a relevant question because is there a need for doing hydrosection, especially because we know that in most of these brown cataracts there's hardly any cortex there or epinucleus there. Do we need to do it? Well, I think there is, you also need to anticipate that in elderly patients, you also have a little bit of a zonular weakness. So even though you don't want the do hydrodissection because there is no attachment to the cortex, to the capsule, but it gives us an assessment of, what is the zonular status. So I always would want to ensure, even using the very little amount of fluid to do hydrodissection, it gives us an idea like, whether the nucleus is truly mobile or not. So that is, whether it's required or not, still go ahead and do hydrodissection, but you need to be careful that the amount of fluid which you're using is very minimal because the bag, there's not much space inside the bag. So that's the reason you need to use very little amount of fluid, and typically if you want to use small amount of fluids in multiple quadrants, and then always decompress so that you don't want the pressure to build inside and the situation where the posterior capsule can blow away.
Dr. Hafa was asking if you remember the CBE in the end of the surgery.
We had done a specular pre-op. It was around 1800, and it was quite good for a 90-year-old lady, but she continued to do well. So there's not much of a significant loss of endothelium post-op.
Can I comment?
Sure.
First of all, congratulations for these two marvelous cases, which were represented beautifully step by step. And this is what caught my attention, apart from your perfect technique, the way of making the videos. So if I can suggest, you use masterpiece cameras, which is, I guess it is Sony A7000, and you were the first one to show how to live stream surgical videos in YouTube, and the visualization of the case makes you a really good teacher. So we need to stress that when we present our videos, how to present them, how to make highlights, how to make stop shots, increase marks. So this is probably a good theme for next webinar, which we need to organize for you, for Dr. Devgan, from Dr. Rosatelli, because the way we present our cases speaks about our work. And especially in your first case, if you don't have such a good equipment for filming the video, you will realize what happened, but the rest of us cannot see it if you not present it like you do it. So thank you very much for the detailed videos and the important key points that you stressed in your videos.
Thank you, Dr. Lukan. You are very generous.
Well, thanks for everyone participating in this meeting. There is a first question here. When would you consider to perform an extra cap instead of a Phaco, if that's
never,
if it's your...
Yeah, I think the choice of the surgery is going to be dependent upon the skill level of the surgery, skill level of the surgeon with the particular technique whichever he is using, and the experience levels. I think that should determine the choice of surgery, because if I'm comfortable with Phaco, no problem, but somebody is not comfortable with Phaco in such a case, there's no shame in doing the surgeon surgery which he is comfortable. Maybe SICs or EPC, both will be fine. See, ultimately we're more interested in the final outcome which the patient is going to have. So that should be your deciding factor.
Great. Again, Dr. Lukan stressed it about Dr. Deepak, but I may extend to everyone who participated here. I think you are really doing a brilliant job of sharing the experiences, and I'm pretty sure that many of the people who were watching this were is inspired by your work in different parts of the world. That's why we started this idea of making this meeting happen. Unfortunately, there were also colleagues that couldn't be here with us, and as Dr. Lukan said, we are also looking forward for the next meetings, so everyone can join. Really, you are inspiration for many surgeons around the world. Please, congratulations for your outstanding job. I'd like to thank again for all the participants and the audience, and I'll let Dr. Chamon also do his closing remarks.
I think inspiration is a great word, and Taguchi was perfect in it. And as I deal with very young surgeons from a long time, I can assure you that your inspiration has moved a lot of walls. So those young surgeons mirror on you. For them, it's an honor to be here and to be listening, interacting with you all. It's important for you to know that this is part of our weekly meeting. We have a weekly meeting for more than 25 years, and when we discuss what is called surgical optics, and it includes cataract surgery, biometry, and all kinds of refractive surgery. So it is a pleasure for all of us having you among us, and we can't thank you enough. I hope you have enjoyed it too. And really, we can't pay you for these 2 hours that you spend with us here. Thank you very much.
So,
Thank you, guys.
Thank you.
Bye.
Bye.
Thank you. Bye.
Bye-bye.
bye-bye, everyone, and stay tuned for our next meetings. I'll send the schedule as soon as we have it. Okay. Thank you, everyone. Stay safe.